Can everyone see that?
Yes.
Now I had to turn the my other computer off because of the echo. So if you have a question, just, I don't know, yell out. How's that? I'm trying to get all this stuff out of the way. I don't know what all you see. Very strange. Anyway, so I'm going to talk about Wallerian degeneration, axon regeneration after nerve injury. Let's see. And as you know, Wallerian degeneration is an active process of degeneration in which nerve fibers are cut or crushed or otherwise damaged. And then a part of the axon distal to that area degenerates. And this part down here is a zone that that you're going to be dealing with often, the part that's gone. It does need to be cleaned up if it's particularly damaged, and immune cells take care of that to get rid of the myelin debris and all. The Wallerian degeneration can go all the way back to the spinal cord, and it can take actually a year or more to develop in humans, where even the neuron in the spinal cord can start to degenerate. That usually occurs when this site of nerve injury is very close to the cell body. So like a root injury, for example. There are two distinct programs that are now known for Wallerian degeneration. The first one you just saw, where you have on the left here, just what we define as Wallerian degeneration, that you have severed axons, begin a series of axon death signaling cascade within a day or so, depending on the species. 1 day is usually a rat, 3 some days is a human. And then there's a delay before that occurs. And then after that delay, suddenly the glial cells engage with clearance. This has now been divided into 2 separate steps that are different programs. The middle one has been shown, particularly in some animals with a Wallerian degeneration slow mutation, that severed axons can remain functional and morphologically preserved for weeks to months. So that's called attenuated cell death. The right one, all the way on the right, is defective clearance by the glia. And that can occur similarly separate from the other events. And it can create a lot of problems in clearing and regeneration, because it creates a lot of debris.
So Mary, just to clarify, the event in the middle and the event on the right are things that happen in normal circumstances?
Well, it's interesting that you say that, because when I was going through all the literature, Justin, they were saying, you know, that attenuated cell death is usually like a mutant or this or that. But I'm going to show a bunch of data saying I don't believe that.
Okay, because I've been running off the premise that what takes place on the far left is pretty much all we're dealing with.
Well, no. I think that what you and I are dealing with in our dog model, some of which I'm going to show, is that attenuated cell death can be enhanced surgically, or of course with various drugs and things, including ascorbic acid, by the way. How much vitamin C do you have? I'm not going to show all that data, but that does exist. Okay. So no, Wallerian degeneration in its full glory does not occur always, all the time. I think that the people who are doing these studies that saying it is are doing mouse and mutant models, or looking at Alzheimer's disease and a variety of demyelinating disorders.
But if we're talking about in the peripheral nerve, though, you're saying that you can sever an axon and the distal end might not degenerate?
You'll see.
Okay, all right. Carry on. Piqued my interest. Continue.
You'll see. It so some of the events that occur that are known at the very beginning, 6 to 24 hours after this initial transection. We're just talking about transections and axotomy via clean transection at this point. That you have a rapid short-term calcium wave. That big wave of calcium is due to like flow out of the injured cells themselves. And then there's some nicotinic and ATP depletion sort of energy losses, and that set off the mitochondria. And the mitochondria release reactive oxygen species, which can be injurious of themselves. And that mitochondria damage then sets off a huge second long-term calcium wave, which can be that increase in extracellular calcium can be quite detrimental to cells. One thing that it does is start destabilizing the microtubules so that you no longer are having transport of growth factors and other factors from the cell body distally. Then once that all is destabilized, once you get to this middle portion here, the execution phase, there's a disruption of the microtubules and a dismantling of the exoskeleton. What one starts to see histologically at this point is swelling and beating of the axon, catastrophic axonal fragmentation, enhancement of the glia and other phagocytes that come in to clear the debris. And then we get into this bottom part. How do you preserve? Like how does it preserve? Is anything preserved? Can you preserve synaptic function? Can you preserve the axonal synaptic structure itself? So what I'm going to show are some changes through here on some differences that this doesn't always occur in this sort of like perfect manner, which is advantageous if you're trying to rebuild it. That you can just have a portion of the most distal gone and you only have to build the end, or the swelling and the beating begins and then the cell manages to rescue itself, which I've seen occur in my rat model, which I'll briefly talk about. The engagement with the glia and other phagocytes bring in cytokines that clear, but also cytokines that repair. It all is going to depend on what happens here at the site of axotomy. Was it complete? Did you rebuild it? Did you put something next to it to regrow? And are there any remaining axons that help attenuate axon death by just growing through and re-innervating the end?
So to clarify quickly, Mary, we're talking about a spectrum of axon injury that may not be complete.
Yes.
Got it. Okay.
It's all about how did that axotomy occur? How much, what occurred, and what did you do immediately to try to fix it?
Okay.
And I was going down this rabbit hole of a working model of Wallerian degeneration because I do find this interesting, as do you, Justin. And I was just thinking, all right, this is really cool. You've got that nicotinamide mononuclear amyltransferase inhibitor system and all sorts of things like this. But this is all about like axon death and axon signaling, death signaling processes. Well, I'm really interested in regeneration. How can I successfully regenerate, like number 4 or number 5 here? Is it partial axon regeneration or total successful? So if we start here, with this one, you've got the uninjured, then you have the initial reaction to injury, usually happens in 24 hours. All these little cells down here that are green are the swan cells that are proliferating or separating from the axons that are not myelinating. And then you have a lot of debris, and then note the little tiny things that are cytokines. These are inflammatory cytokines, but they can also be growth factors because the main purpose of the body is to repair itself quickly and successfully. Then you have the onset of Wallerian degeneration, which is the loss of the axon here about a week. This can go for weeks to months. But look at the same sort of thing. You also have, at the same time, these Schwann cells are lining up into tubes. These red things are macrophages. They're clearing out the debris, but macrophages come in subgroups. They're showing you only here the activated inflammatory cytokines, macrophages, but you have resident macrophages switch into activated, then they become type, so those are type 1, then they become type 2A, type 2B, type 2C, all these different macrophages which are recruited or either altering. Purpose is to clear the damage and then bring in growth factors and release growth factors for repair. So they're not all bad, the macrophages. Many of them are good macrophages for repair. And so that eventually, weeks to years, you get a whole successful reinnervation. And you've seen studies like this. I'm sure that at this whole end down here, the denervated Schwann cells, but they're starting to proliferate because they're being exposed to a lot of mitogens, receptors, and cytokines, and all sorts of things that are allowing them to proliferate to try to maintain something down there, like a sheath, pathway for the axons to regrow. The neurotrophic factors are changing from the glial cells themselves, satellite cells, as well as Schwann cells, trying to like give a regrowth, a regenerative process. There's a decrease in myelin associated genes down here as well, and degraded myelin, but that's just because the Schwann cells have altered. So if we go back to our point of regeneration, Coleman and Hoke, who also did that whole death panel, also says, well, the whole point in the end is an axon regeneration, that you want the axon to regenerate from the lesion site. It does not, it do have to get building components from the cell body, but it really only has to build from the lesion site out. And then successful reinnervation is, did the axons find their target? But I think that is also how far it went.
Can I interrupt you with another quick question?
Sure.
Okay. One of the concepts that was introduced to me recently that I hadn't considered previously is that the machinery for regeneration isn't just at the cell body, but there are nodes along the axon.
That's right. So when they show you this picture like this, and they talk about the mitochondria up here or lost, well, it's now known very clearly there's mitochondria all down through the axon too.
Okay.
And that is probably what's helping stabilize everything. That means that there's RNA, there is actually some ribosomal nucleotides down here in the axon, and mitochondria. And they are working down here to try to give energy and rebuild. The glial cells are also, the purpose is to rebuild. These glial cells though here, whether they're the Schwann cells as shown or the satellite cells, are working hard to rebuild. So what we are often shown is this doom and gloom part for Wallerian degeneration. But pedal to the metal, I see, is that it's not so as doom and gloom as this, that there are ways to halt it and repair it, even back to almost the way it was. Now, it does depend on how bad that axon is. This is actually true in terms of how bad is the axon that was damaged. When you look at a lot of the biomechanical material testings, you know, they test in these rigs, there's the nerve. Sometimes there's a weight, you can really like get this a high energy damage, and you're loading the in various, it's usually listed in megapascals now, with the elongation and the speed and everything. And this bottom line part and these pictures on the right seem to be the key to how well you can get an axon regenerated. And that is, how bad is the damage? In a normal nerve, you only see through here after elongation within this zone of elasticity, the proportional limit of the axon. You just see a little bit of damage in the epineurium, let's say. But if you have a high energy, like a whiplash energy, or a person who, you know, zoomed off their motorcycle and separated their head from their shoulder with a telephone pole, you can have pretty bad damage, and it can look like this. This is the very hard part to rebuild and regenerate. This is the difficult axon injury, when the insides, the funicular portion of the nerve, are quite disrupted. The perineurium, which you see through here, is disrupted, and the epineurium. So of all the connective tissue layers, and the inside no longer look intact like you see in A and B, but instead they look more like C, or particularly D. You have a very difficult axon injury.
Yeah.
So instead of going through that rabbit hole of mechanisms, Justin, I went through the mechanisms that I know and have seen in my different work with you and Mike Ruggieri. And in my rat model, you'll see some as well. That we did a lot of urinary reinnervation strategies, where we were comparing the effects of root or nerve transfer that we moved to the bladder, with the purpose of reinnervating the bladder using cat and dog models. And I'll give you the bottom line first. The timing of the surgical repair matters. The faster you get in there and repair, and then of course, the less damage there is, the better the reinnervation is at the end. So in the first study, it was that I want to present, it's the cat model, where we're doing the Zhao technique of lumbar to sacral root rerouting to restore bladder function in the feline spinal cord injury model. And there was urodynamics and retrograde tracing and a lot of histology performed. And just to kind of give you the design, there's a spinal cord transection, and then the L7 root is rerouted to the S1 root, so that it was supposed to give you like a scratch stimulation. So if you scratch your skin out here at L7, that the information is coming in on the dorsal root from L7, and then coming out the ventral root of L7, which has now been sutured to the ventral root of S1, and that will go out to the bladder. So you have like a scratch bladder stimulation. And
just for all those who don't know the cat anatomy, it's obviously very different from the human anatomy. Ours is S2, 3, 4, cat's S1 innervates the bladder, and we don't have an L7, but they do. So
thank you. Yeah. Well, the cats probably have some S2 as well. The dogs I know have L6 to L6, L7, S1, 2, 3 can all possibly innervate the bladder, although there's primary input from S2 and 3. But there's obviously variations with species, but variations within the species, and variations even human to human. So as an anatomist, I can tell you that thank goodness we all have differences, so because that helps us with rehab. Now, my part with all of this project was the histology. There were other people involved in the surgery, but I want to present this to you because I was fascinated with how well the histological recovery went. In this one, here's our spinal cord, and this is the ventral root of L7. This was the L7 to S1 reroute was cut during terminal testing to prove the point, the proof of the pudding. Did it really work? But the anastomosis site I found here, it's this bump right here, and the roots was the anastomosis site, and then here's the S1 ventral root. what I saw histologically is that a pure transection, I think this one shows it well. Here's like the suture site. Sutures, interestingly enough, histologically, under immunofluorescent lights, fluoresce, usually a very nice blue, which allows me to find them under a microscope quite successfully. Sometimes when people use a blue-green suture, I can actually see it under hemotoxin and eosin. So these are hugely advantageous points to use as an anatomist when I'm looking at how bad was the damage and how well did it repair. But in A, like the transection was like here. So they just did a clean transection and then re-sewed the roots immediately. So it was, and then you can see one's a little bit, this is cat 5, it was a little bit messier here. But in these like clean transections, when I look at the tissues 10 months later, now it's 9 to 10 months later, look how regrown this is. So everything looks quite nice with the L7 to S1. You can see axons coming through. C looks really beautiful with, it looks like a complete root that never got touched again before, except I can find the suture sites with epineurium have been sewn together. There was some variability. Cat 5 was a little gnarly, where you can see a big scar here near the suture, but there still was regrowth across the reroot site. And then here you can see some scarring through here, but that's the dorsal root ganglia on the bottom of E. But there was some passage, although it's zoomed out of this sort of point through here, but when I looked at the fluorescent dye, there was some passage of axons from distally to proximally to the spinal cord.
And one more point of clarification, Mary, for everybody who's watching. This is intradural nerve rootlet before, this is proximal to the dorsal root ganglion.
Yeah, so this is the site here.
Yeah.
So they were intradural.
Yep.
And so they're sewing it right at these points together and doing a reroot like this inside the dura.
Yeah, there's been some debate amongst folks as to whether intradural nerve repair works, and I think you've demonstrated nicely that it does. It's technically challenging, but it does work.
I would say it's quite technically challenging, and that's why they probably have some of this variation in how well it went through here.
And then the only axons that we're looking at here are going to be the motor axons, because the sensories aren't going to retrogradely grow up and re-enter the spinal cord, correct?
That's right. That's correct. That's correct. But nothing's keeping the axons in the spinal cord from coming out, right? So what we're looking at here in F are those motor neurons. These are the motor neurons that are left in the spinal cord of these animals. There's L, I cut this longitudinally so I could see it all very clearly. So I have L7, S1, and S2. And you can see some interesting sort of like differences side to side.
Yeah.
That's probably based on some died in spaces, right? And some got bigger in other places.
And one other point of interest here, like you talked about at the very beginning on Wallerian degeneration, is this is done immediately. If you cut roots within the canal, you then deprive that cell body of the neurotrophic support of the Schwann cells, and it undergoes apoptosis. So if you came 3 months after cauda injury, you probably wouldn't have a lot of motor neurons to recruit from, right?
Right, right. That's why using something nearby that could be spared might be a better idea.
Yeah.
If there are any roots still spared, depends, because cauda equina can be messy, or it can be, you can still salvage something. Now the fluorogold, a retrograde dye called fluorogold, which is gold colored, was put into the bladder, and I could see some here in the spinal cord at higher power. So there was reinnervation of these motor neurons to the bladder. They did regrow through the site and back to the bladder. This was quantified, as you'll see here. So the fluorogold was injected into the bladder. So when you see it in the spinal cord, it's because these motor neurons had already grown out into the bladder and were innervating it at the time of fluorogold injection, which was 3 weeks before we collected the spinal cords, which was 9 to 10 months after all of this reinnervation had occurred. So they had a long time to regrow, and you can see ipsilaterally that there is a lot of regrowth. There's a lot of fluorogold neurons here in L7, S1, and many of the neurons, and many of the cats. We had 7 cats. But look at cat 6. I was like blown away. Wait, ipsi and contralateral look the same. Oh my goodness, I thought to myself, and I counted and counted and had someone recount again. But fortunately, when I was dissecting the cats originally, I took a lot of photographs. When I went back and looked at this cat in the photographs, even though they were suturing left to left S1 to left ventral root of L7, somehow when they cut, because they cut the opposite side, when they cut it, the ends of the right S root flipped over and stuck itself also onto the same site. And you had to like lift the spinal cord and the roots and move them over. So you could see I had to move them over. And what I could find was that, and histologically you could see it, that the right S1 was actually attached to the left ventral L7. So there was an axon growth across this, explaining this. So what I learned from this is that these roots can really grow.
Yeah.
They can grow even when you don't want them to grow. It wasn't the plan, but you can see how successfully it grew, even though it was a mistake. And it was a good mistake as far as I could tell, because it allowed me to understand how plastic these ventral motor axons are. So that was the main thing, is that the roots were transected and repaired on the same day, and they showed excellent regrowth. Even when there was an unintended root got next to each other and you had aberrant regrowth, it was quite successful. So if we go to the next series of study, these are on dogs. And in this one, we're using somatic nerves that we're moving and trying to move to the pelvic nerve of the bladder as a transfer reinnervation surgery. And it was either done immediately or 1, 3, and 12 months after the bladder decentralization, in which we separated the bladder from the spinal cord innervation by cutting the sacral roots. And in the first series, we were just doing root to root repair. And so it was just cut the roots, put them back together again. We also added some growth factor, the brain-derived neurotrophic factor via an Alset pump, because it seemed like a really good idea and lots of people were doing that at the time. We had some electrodes implanted just for the functional electrical stimulation. And then we compared the results to just sham controls. And what we saw is there was a lot of nice regrowth. Remember, this is just root to root, immediate repair, and I could use lipophilic dyes and could see the dyes coming from both proximal and distal to the repair site. If I looked at the roots, I see fluorogold that had been injected into the bladder in the roots and cross section. You also see some blood vessels in here. I don't know if those blood vessels are a consequence of normal anatomy or the surgery. And when I look in the spinal cord, I see a lot of retrogradely labeled neurons that had taken up dye from the bladder. So excellent regrowth. If I look at the root to root site, just like in the cats, you see you can find sutures, and therefore this is the site of anastomosis. And you see a lot of the dye across there. The BDNF was interesting though. The axons grew out of the pump area and toward the pump and kind of made a neuroma. That turned out to be a bad idea. We haven't done that since at that repair site. But regrowth occurred. We had excellent regrowth, and we're very happy with this in the end. So root to root, immediate repair, success. what about if we go longer? So we've done several with a genitofemoral repair, where we moved the genitofemoral to the pelvic nerve, and we did it either immediately after the sacral root transection, or 1 to 3 months delay after the sacral root transection. And what we see is immediately that there was functional recovery. Electrical stimulation of the pelvic nerve led to bladder pressure and urethral flow. And these are several studies combined in 29 of 36 dogs with immediate repair. And there was a lot of retrograde labeled neurons in the spinal cord, indicating further success. If we go 1 to 3 month delay before repair, it's a little bit less sort of robust in terms of the functional reinnervation, but we do still see abundant numbers of retrogradely labeled neurons in the upper lumbar core, which would be the origin of the genitofemoral. One animal, one side did not, due to fibrosis. If we look at the bladder, you go, excellent. You can even see the ingrowth of the axons into the bladder. So from this, I took Justin, right, what you were asking me, it didn't all die back. And I don't think it all regrew. These are just the di labeled neurons in the bladder itself. And some are going to the muscles, and some are going to the ganglia. And I think that the reinnervation, you could see how pretty it was in this one through here, but in these other ones, I don't think that the nerve dies all the way back, which I'll show you in just a second as well. So we moved on. Justin's been part of these studies where we did a series of decentralization and different time frames, where we either we've got cut the hypogastric, cut the sacral roots, or even cut the sacral roots plus lumbar 7, because it also is carrying some to the bladder. And then we did like 6 months recovery, or a delay before we reinnervated, or 9 to 11 months, or 12 months. And the most disturbing part with this is that the bladder wall was affected. So it doesn't matter what the axons are doing in the nerves. The end target altered considerably, where there was a loss of intramural ganglia in the end target. So in this case, even if the axons got there in a reinnervated sort of neurotransfer manner, what is it going to innervate?
And this is not due to the repeated bladder infections and the rest of it. This is due to loss of axon support, you think?
Yeah, this is just because the longer you wait before you reinnervate, the fewer axon cell bodies are left in the intramural ganglia of the bladder wall for those neurons to come to. So you've got the ganglia the bladder has an intramural ganglia, which need to be reinnervated to cause bladder contraction. The longer you wait, the less they're there. But you think to yourself, oh, there's only an N of 3 here. So valid point, let's do more. So we did 8 of those animals for reinnervation. And the same thing, this is sham. These are 12 months, so 8 to 22 month decentralized, and then 8 to 12 month delay before nerve transfer, and then another 8 to 10 month recovery. And the longer you wait, the lower the integrity of the end organ, meaning the harder it's going to be to reinnervate, because you've lost some features of the end organ that are needed for function.
Can I ask a quick question about this? This is very interesting, and it makes sense in terms of that you'd have this lower density of ganglia. But how do you, if it's too technically involved, please, we can save it for later. But how do you actually calculate this on a tissue that has such variable dimensions, and how do you control for kind of the change in the size of the bladder after an injury like this. I
Yeah,
guess kind of how do you standardize it across animals?
exactly. Ben, you have a very good point. We always did this from the exact same zone of the bladder. We need to recount this now from the other zones. So we always did it from the anterior lateral sort of zone of the bladder, mid bladder. So we divide the bladder into upper, mid, and neck, and then ventral, ventrolateral, dorsal. And we always collected from the exact same site and the exact same size of tissue. And then we had to normalize it. So it's the number of ganglia per bladder wall area, the number of neurons per ganglia per bladder wall area. So there's a lot of normalization to get this answer.
I see. So let's
Yeah.
say if in a animal where the bladder doubled in size.
Oh, and ours,
How do
yeah, exactly. That's why it had to be normalized to the bladder wall area.
I see, but let's say the total volume of the bladder has now expanded greatly, and you've taken the same size, like postage stamp of bladder wall,
Well, it's
but
actually a pretty
if
chunky size. It's
oh, it
but
is.
yeah, we take a pretty big chunk.
Okay, sorry,
It-
I just kind of
it's
getting
so
No,
at
no,
like
no,
how
it's a
much.
valid,
Yeah,
it's valid, Ben. It's very
yeah.
valid. And it is the sort of the nemesis of doing this sort of work is how do you normalize? Yeah. So we didn't try to do just like look at one section. We did what's called a exhaustive examination of the sections, meaning we had 3 different people looking at every section we had to look for
Okay.
any presence of ganglia there, in case it was a rare incidence phenomenon, right? But if I keep going, we also saw a bunch of fibrosis, which is your point, Ben, right? That the wall is thickening. There's an increase in fibrosis with the long delay, except for one animal where it just disappeared. I don't know, the percent muscle is gone. Look, it's just like, whoop, there it goes. This animal here, this particular animal shown in J, had the lowest function left. And it's because the bladder kind of died, the muscle itself. So it's the one with the lowest here. And so we also had a huge increase in inflammation, which Justin talked about earlier. But despite that, we did see an increase in growth. So here's sham, decentralized, and here's the increase in growth of axons in the reinnervated animals. So the number of axons in that same bladder zone wall increased. But that's obviously, there are, as you're pointing out, some foibles to histology. So then one has to go to function. And you're looking here at if you're stimulating the nerve itself, pelvic nerve, or the transferred nerve, and it doesn't look so good if you're stimulating the nerve itself. And mainly that's because of all this fibrosis here around the nerve. Although, note, there's still axons here, and the axons are still going across through here. And back to the point of our reinnervation studies, I don't always see that this has disappeared. I often see, I can find a nerve. If I find a nerve and it still has turgor to it, I know there's still axons in there. If it's a very flaccid nerve, I know it's disappeared, and there are going to be no connective tissue components that are the turgor part or axons on the inside. So you can actually tell I can tell when I'm collecting the tissues if that's a viable nerve or not, by just how elastic it is. And this one does have fibrosis, and that fibrosis did reduce some of the maximum detrusor pressure. But if we go back to the spinal cord itself and stimulate, you can see there is a success in that 7 of the 8 animals, although this one's kind of splitting hairs here, had a strong reinnervation there. Actually, when you stimulate the spinal root, you have a bladder contraction. And that's from the upper lumbar areas where the genital, in this case, the obturator, where the obturator is originating from, compared to if you're doing just the sacral. And this did correlate with the amount of axon density and inflammation and the number of ganglia in the bladder wall. So if you have ganglia left, the spinal cord apparently found a way to grow there and reinnervate. It wasn't necessarily through this site that we were moving. Remember, nerves can grow in a variety of ways, and we likely had nerves from lumbar plexus and pelvic plexus all sort of coming here trying to reinnervate, because the bladder is sending out chemotactic factors, you know, innervate me. And you have some things still coming through here, and the spinal cord apparently still attempted a regrowth and was successful in several of the animals. Does that kind of answer your question, Ben?
Yes, yeah. I just, it makes sense. I just kind of was more mechanistically trying to figure out how you did it and controlled for things. That makes sense.
It took us about a year to do it correctly, Ben, is the answer. Because I had people do it. I had people do it over and over and over again, because I wanted to make sure, do it this way, do it that way, do it this way, until I made sure I felt like we were answering the question. So the conclusion of this is that with this long delay, we did have a loss of function, mainly due to a loss of intramural ganglia and the ganglionic neurons and some smooth bladder muscle loss. But in the ones where you had enough of those ganglia and smooth muscles remaining, you saw a reinnervation with this long delayed obturator pelvic nerve. I believe a shorter time frame is better for the reasons I've shown you, that less is happening in the target and less is happening in the axons themselves. Now, the reinnervation, I think, was because the axon sprouted and they found a way to get there and reinnervate. But I do believe that this combination of long inflammation and fibrosis was a problem and detrimental to function. I believe this because I've looked at this in the rat model that Justin talked about. And repetitive overuse injuries can also cause nerve damage, usually a constrictive nerve damage, which we often call carpal tunnel syndrome in humans, if it's the median nerve, and a loss of function or a change in function, increased pain and loss of motor function. So I've tried to sort out that fibrosis question by blocking nerve fibrosis. I was blocking connective tissue growth factor, also called CCN2, using a drug called FG3019 or pamrevlumab. It's now in phase 3 trials for lung fibrosis, idiopathic, and they're doing COVID as well now, and some other disorders, cancer-related fibrosis. In my rat model, they do this whole operant sort of thing here, which I can't talk about too much, but you can see they're pulling on that lever bar for food reward, and they do this for weeks and weeks because they really like these banana flavored foods. And I had them doing it up to 18 weeks, and they develop all the signs of a constrictive nerve carpal tunnel syndrome, fibrotic mononeuropathy. So they do that task 18 weeks untreated, or 18 weeks, and then they get a control immunoglobulin drug, or they get the anti-CCN2, which is the antifibrotic drug, FG3019. And we see, just like you have in people with median nerve mononeuropathy, you have a loss of grip strength, and that would be in red for the IgG control treated animals, but it improves the control levels if they get the FT3019. They have a cold aversion, so they have an increase in cold temperature sensitivity. And then when I do a native system, the human is the same as the human. You just use smaller electrodes for this testing. I can see that the median nerve has a loss of conduction that is improved with the FT3019. So when I go to try to see why, I can see there's a lot of degraded myelin in the untreated animals, and then the rest improves it. But the FT3019 treated animals look like controls. So the degraded myelin has gone away. This is interesting because this drug, FT3019, has been used for in an animal model of inflammatory encephalopathy, and it also improved myelin function and presence. I can see there's a huge compressive, sort of like fibrotic sort of area around the median nerve at the wrist. And I think this is a compressive mononeuropathy. And when I give the FT3019, then the animals look like controls, so that collagen deposition goes away. But back to Wallerian degeneration, I look at the spinal cord, and these are all ventral horn neurons and the cervical spinal cord. In untreated animals, I see this huge increase of ATF3 in the nucleus. That's bad. ATF3 is activating transcription factor. It's not normally found in neuronal cells, but it is highly expressed when you have nerve injury, but only in the nuclei that have regenerative competent neurons. So I have the onset of Wallerian degeneration in these rats, in their ventral horns. Rest makes it better. The FT3019, there's no more green. They look like controls, meaning they are improving. If I look at the dorsal root ganglia, there's a big increase in substance P, so they're not undergoing Wallerian degeneration. There was no ATF3, but they are undergoing central sensitization in reaction to this sort of inflammatory compressive mononeuropathy. And so if I bring that back to this idea of Wallerian degeneration, they do appear to have a chronic constriction nerve injury that is leading to some changes in the spinal cord that are like the onset, the early stages of Wallerian degeneration. But if I use this FT3019 to block connective tissue growth factor signaling, it reduces fibrosis, and it's improving their function. So in this case, I just would like to bring back with Wallerian degeneration through all of this. Yes, you have neuronal dieback from a variety of like transections or injuries, in this case a mild injury, but it is the onset of Wallerian degeneration. But if you anastomose or try to repair it early, you have very good success, I think, of repairing. As you could see in all of those images, the nerve was still there. Those nerve trunks look pretty good, didn't they? They didn't disappear. I don't see this huge disappearance of axons distally, except, Justin, as you asked me earlier, in those very long-term animals, where it's 18, 22 months after the original sacral denervation. Then in those, the nerves are flaccid and there's no axons left, way down there distally. So there's time to do the reinnervation, I believe. There's time to save the axons, and especially if you can anastomose, repair surgically, and end on end. I think this other methods probably work too, but we've had the best luck with end on end, where you just put them together. It gives the axons a sheath to grow through. The swan cells haven't disappeared. So when I'm looking at it histologically, I don't see this doom and gloom of Wallerian degeneration until we waited 18 to 22 months.
Yeah.
Then the end organ target is affected badly. The axons have disappeared. Or we do see ATF3, that injury marker in the spinal cord neurons of those same animals, Justin. We just haven't published that part yet. And it's there. We're in need of rescue early. In the rat model, I was able to rescue by reducing inflammation with rest and the drug, and by reducing fibrosis. So that was a successful strategy for me for that model.
Another question for you on that front, Mary, is there's been a little bit of a debate as to what's the primary player in unsuccessful regeneration late. And at the conferences, everybody talks about the motor end plate and the muscle fibrosing or being lost and so forth. But a lot of the basic science, like Tessa Gordon, points to the distal nerve itself, the degeneration of the endoneural tube, the loss of the Schwann cells, the shrinkage, mechanical impediments, and so forth. Can you speak in the bladder scenario to how much the nerve, the distal nerve itself, might contribute to that failure?
I think, Justin, when there is strong evidence for two different scenarios,
yeah,
that both are working simultaneously, right?
Yeah.
So I see both working simultaneously in the dog models as well. That the end organ counts. I didn't start seeing the loss of integrity of the bladder until about 12 months after decentralization.
Yeah.
And then there was a precipitous decline by 22 months, right? It really looked bad in some animals, but it's still hanging in there. There's still some salvageable nature of it, even after all that time. The axons also, if the axons had a target to get to, if they could get to something, they're obviously maintaining in many cases. Yeah. But it's the combination. The worst case scenario animals was when the end organ was gone, right? Like there was no muscle left, there's no ganglia left to innervate. The axons are flaccid, and the nerves are flaccid. There's no axons left. You put that together, and it was the worst case scenario.
Yeah.
So it's like when you're looking at your patient, you're thinking to yourself, when you're choosing whether you should or shouldn't try to do something for this person to help them, what's their muscle look like? Or do you need to use a new muscle and bring a new muscle from a new place and transplant that? Right. Does the end organ have enough integrity to drive function? If not, what strategy can you use on that end? How about the nerve? Does the nerve have any turgor or elasticity left? Because you can tell physically touching it. Yeah. Or should you use a new nerve to bring it over? Should you bring in some new transplant nerve and a new graft to bring in a healthier nerve to reinnovate? I think that's the strategy, is choose, is it end organ? How's its integrity? How's the integrity of the nerve? Which one's better? Which strategy can you use to have the best outcome?
Yeah.
With the parasympathetic, they have that ganglia that's close to the cell body. So that you could say is a secondary reservoir of something that could like finite. But in motor systems, there isn't that ganglia. That's the difference between motor and parasympathetic or even sympathetic systems. So do you think that the presence of that autonomic ganglia that's near the target actually prolongs the effect of a nerve injury that's close by? Because you would think cell body target is actually smooth muscle. So you're kind of like. So
I think that I agree. I think that autonomic ganglia in the end organ is helpful. I can tell you that we see that it's not as simple as it seems, though. Even with the bladder, there's direct input to the bladder from the spinal cord. as well. There isn't always an intramural, like the autonomic ganglia sitting in the middle, like the pelvic ganglia. There's some of those axons shoot right through. So we have 2 neurons, 1 neuron direct input, as well as the 3 neuron and 4 neuron ganglia synaptic relays for bladder function. It's not as simple as we taught you in anatomy. I'm so sorry. But when
doesn't it look like that the bladder wall ganglia is almost a homologue to the motor end plate in the muscle? It's degenerating in the same fashion. It's almost on the same time scale.
It really is almost on the same time scale. But if we go back to skeletal muscle, you can, it's hard for me to believe that the motor implant can't be rebuilt or something.
Yeah.
The muscle is so plastic, skeletal muscle that is so plastic, and so many things can occur. There are so many repair processes for skeletal motor, and even from a neuronal standpoint, I don't think we truly know yet the full extent of plasticity and what we can drive.
Yeah.
Yes, what you're saying is correct. There's a big difference in an autonomic muscle and a skeletal motor muscle. But there's still lessons to be learned in terms of the integrity of the end organ itself.
And the last clinical piece to comment on there is that it seems that we can reconnect sensory axons quite late. I've done it even at 5 years, and it has reinnervated the targets we've sent it to. Probably less robustly than it would have otherwise, but it does go there and it does provide sensation, whereas no way after 3 years would I expect any motor contraction. And so I guess the question is, are sensory axon regeneration, is that more robust than motor, or is that entirely dictated by the end organ then?
Yeah, it's interesting. I think it's because sensory has more things that can innervate. So the sensory neuronal cell bodies in the dorsal root ganglia.
Yep.
But what we often teach you is like one dorsal root ganglia goes to one end organ, when in fact the truth is 5 to 10 dorsal root ganglia are innervating the same end organ. And so the question is, when you're moving, Justin, and you're moving a composite nerve, what's in there? In that composite nerve, you might have lost the dorsal root ganglia to C5 due to Wallerian degeneration, but you have still the dorsal root ganglia to C6, C7, or maybe even T1. And those dorsal root ganglia axons are still growing out the end organ. And they're plastic enough, they can reinnervate what they want, right? They are plastic. It's really like, what is the end organ sending out in terms of chemotactic factors? Is still anything there to attract a new dorsal root ganglia axon from another site that's still maintaining itself in there? And can you make a functional synapse that your spinal cord and your brain can retrain to understand?
Perfect. Hey, Mary, that was awesome. We've hit the 9 o'clock mark and got to run see our patients. That's exactly what we were looking for. Thank you so much, and we will talk soon.
Bye.
Bye. Oh, you do it.